Hello everyone, myself Dr. Anubhav Sharma from ITS Dental College, Murad, Nagar, Ghaziabad. I am a reader in Department of Public Health Dentistry. Today I will be discussing about pit and fissure sealants. So to beginning with, first we should know what are pit and what are fissures. So pit basically it is small pinpoint depressions which is located at the junction of developmental grooves or which are present at the terminals of the grooves. So basically these are the pinpoint depressions which we generally we can appreciate, which is present on the tooth surfaces or occlusal surfaces. Then what are fissures? It is basically a deep clefts which is present between the adjoining cusp, and they provide areas. So these both pit and fissures provide the areas for the retention of caries producing agents like streptococcus mutans and lactobacillus. Then water sealants. So it is basically a thin plastic coating like material which we applied onto the chewing or occlusal surfaces of the posterior teeth. So if we apply these sealants on the tooth surfaces, it acts as a karyostatic action. So basically after applying sealants, they can provide an obstruction to these caries producing bacteria. So it provides as a barrier which prevents lodging of fermentable carbohydrates and prevents the colonization of bacteria over the pit and fissures. So if we look onto the history, in 1905, Miller described a silver nitrate material which we can apply over the two pit and fissures as a pit and fissure sealant. Then Hayat in 1923, he has proposed a technique named as prophylactic odontomy, where it consisting of filling the fissures with either a silver or copper oxyphosphate cement as soon as the teeth is erupted into the oral cavity. Then later, when they are fully erupted, they prepare a small occlusal cavity and filling it with the amalgam. Then Bodecker in 1929 proposed a technique named as fissure eradication. It involves widening the fissures mechanically so that they would be less attractive to the food particles. So it is known as fissure eradication. Then Bunecore in 1955 introducing another method of adhering the resin to the acid-etched enamel surface. In somewhere in around 1960s, first material used experimentally as sealants, which is known as cyanoacrylates. Then in 1965, Bowen developed the bis-GMA resins, which is a chemical reaction product of bisphenol A and glycidyl methacrylate. Then this material is recognized by the FDI in 1975. So this is all about the history of pit and fissure sealants. Then we can classify these sealants as based on generations. Like first generation, we use UV light as with wavelength of 356 nanometer. But the disadvantage of ultraviolet, as you all know, that it is harmful to the body, and it is also incomplete. There is also incomplete flow of sealants to the depth of pit and fissure sealants. So a second generation has been developed, which is known as cell curing sealants, which is a chemically curing resins based on a catalyst and accelerator system. It can be a transparent, tinted, or opaque due to inclusion of a pigment for better visualization. Then comes the third generation sealants, which are polymerized by visible light of wavelength of 430 to 490 nanometer. Then comes fourth generation sealants. Here they have added a fluoride for double protection. Then they can be also classified based on the fillers. It can be unfilled or semi-filled. In unfilled, it has a better flow because they are free of fillers. They have good retention, but it abrades rapidly because of lower strength. Then semi-filled, semi-filled are means they have fillers. They require occlusal adjustments, and they are more resistant to the occlusal wearing. Then they can be a colored one, sealants. It can be a clear one, it can be an opaque or a tinted. So colored sealants are easily identifiable, but if it is clear, then it is difficult to identify. Then there are some ideal requirements. It should be present in the pit and fissure sealants, that it should be non-toxic and non-irritating to the oral cavity. It should provide a good adhesion over the pit and fissures. It should have an adequate consistency and viscosity. It should have minimum shrinkage after polymerization. It should have low solubility in oral cavity. It should have sufficient compressive and tensile strength to bear, and it also should have charismatic properties. Then morphology of pit and fissure sealants. Nango has described four types of fissures based on the shape of the fissures. It can be a V type, it can be U type, it can be I type 1, it can be K type. So V and U shape generally are shallow and wide. It is self-cleansing and it is caries resistant. And I and K shaped are deep and narrow one, and these are caries. These are more caries susceptible. So these are V type, V type, U type, then I type, IK type, and Y types. So V and U are more caries resistant, and these all others are more caries producing. Then why it is considered that pit and fissures are more prone to caries? It is due to the it provides the bacteria and nutrition harboring harboring or rendering area, and also it is more close to the pit and to the DEJ, so it provides a nidus to the bacteria and to grow there, and also it, continuous availability of nutrition will help in harboring, will help in growing. Also it is these areas are quite deep, so it is quite inaccessible for mechanical debridement. Then how these sealants work? So it physically obstructs the pit and fissures, thus prevents the lodging of the fermentable carbohydrates and colonization of bacteria. Then basic composition of sealants, which is now available. It is mainly composed of resin matrix of bis GMA. Fillers are like a micro and micro one, and macro is quartz, and micro are amorphous silica. A coupling agent to unite the resin matrix to the filler generally used are titanates and zirconates. Then it has an initiator and activator system. Initiator is benzoyl peroxide and activator is tertiary amine. Inhibitors are like butylated hydroxytoluene to minimize the spontaneous polymerization of monomers. And opacifiers we use are aluminum oxides and titanium oxides. So it is generally considered at primary dentition. If you want to apply the pit and fissure sealant in primary dentition, 3 to 4 years is considered to be ideal. In mixed dentition, 6 to 7, and in permanent dentition, 11 to 13 years is considered to be ideal for application. What are the ideal indications for pit and fissure sealant application? Newly erupted teeth, the teeth with minimum decalcification, then tooth in question has erupted less than 4 years, and teeth with no evidence of proximal caries. So these are the some of the indications for application of pit and fissure sealants. Then contraindications, like individual with no previous caries experience. If there is no previous experience, then there is not required of pit and fissure sealant. Then teeth with wide and self-cleansing fissures, teeth that cannot be isolated, and then the pit and fissures which doesn't have any carious activity for 4 years or more than that. Then armamentarium which we generally use in pit and fissure sealants are mouth mirror, explorer, tweezers, pit and fissure material, etchant, light curing unit, pumice and prophylactic brushes, articulating paper, and sealant polishing cups. Then these are the 6 steps of sealant application. First, we prepare the tooth. How we do? Like we do, we cleanse the occlusal surface of the teeth so that all the plaque and debris which is present in the pit and fissure sealant should be removed. And also when the pit and fissures are clean, the etchant can easily penetrate through the pit and fissure sealants. So polishing is done by the pumice and the prophylactic brushes. Then we isolate the tooth with the cotton rolls. Then we acidize the tooth surface with 30 to 50% of orthophosphoric acid for about 15 to 30 seconds. So these are available in the gel or semi-gel forms. So why we apply acid etch? It removes the organic materials and debris from the surfaces, and it produces the micropores of around 50 microns meter into which the monomer can penetrate. So we can apply it by cotton pellet or brush, or we can directly apply it by the syringe. Then after 15 to 20 seconds, then we rinse with the water for 10 to 20 seconds, and we dry the tooth for additional 10 seconds, and we look it for about then we look at for the teeth surface is having chalky or frosted appearance. Then drying is usually preferred by the chip blower rather than the three-way syringe. So if we found that any contamination occurs during this process, then we can re-etch for the another 10 seconds. Then we apply the sealant over the pit and fissures, and also we should be careful while applying this that the pit and fissure does not having air bubbles while its applications. So then the material should be polymerized for about 20 to 40 seconds by the visible light. Then after 20 seconds of curing, then we check for the any high points. If high points is present, then we should remove it. So we can check the high points with the application of articulating paper. If any occlusal interference is present, it should be removed with the burr. Then also the last step of the sealant application, it involves that we should educate the people and the patient and the parent also for its periodic evaluation, and it should be evaluated after every 6 months. Now we will demonstrate the pit and fissure sealants clinically.
Today's topic is pit and fissure sealant application. Fissure sealants are the material designed to prevent pit and fissure caries when they are applied to the occlusal surfaces of the teeth in order to obliterate the occlusal fissures and remove the sheltered environment in which the caries may thrive. Are small pinpoint depressions located at the junctions of the developmental grooves or at the terminals of those grooves, whereas fissures are long clefts which are present between the cusp or ridges. There are basically two types of fissures, V type and I type. V type are self-cleansing and somewhat caries resistant, and I type is most caries susceptible. Now beginning with the application procedure. The material we used are cyanoacrylates, polyurethanes, dimethacrylates and GIC. We check for deep narrow patent fissures and those teeth which are recently erupted teeth, and those children who are at higher caries risk. Then we polish the tooth surface. It is absolutely necessary to remove the plaque and debris from the enamel and patent fissures of the tooth. Any debris that is not removed will interfere with the proper etching process and the sealant penetration into the patent fissures. Polishing can be carried out by using prophylaxis cup and pumice. Then rinse thoroughly so that all the polishing agent is removed. Now isolate the tooth surfaces and dry the tooth, which is absolutely imperative to keep the tooth free from the salivary content. Now acid etch the tooth surface. Acid etching removes the organic material and debris from the surface and produces micropores into which monomer can penetrate. Generally, we use 30 to 50% of orthophosphoric acid, which is used in the liquid form for about 30 seconds. This allows the sealant to penetrate about 50 micron of enamel depth. Tooth should be rinsed for approximately 30 seconds so that all the etchant is removed from the tooth surface. The tooth should be dried with compressed air. The tooth is dried until it has a chalky frosted appearance. If it doesn't appear, then the tooth should be re-etched. Remember that it is imperative to avoid salivary contamination. It has also been seen that moisture contamination at this stage of the process is the most common cause of the sealant failure. Now apply the sealant material smoothly along the pit and fissure of the tooth surface. Make sure that the air doesn't get entrapped in the pit and fissure sealant. Move smoothly number 23 explorer along the margins of pit and fissure so that the air doesn't get entrapped into the fissure sealants. Now the sealant should be evaluated visually and tactily. Take the explorer and attempt to dislodge it from explorer. If there are any deficiencies in the material, more sealant material should be applied. For occlusal high points, and if present, correct the occlusal high points. Since occlusal high points, if present, they are more likely to get dislodged.
So that's all for presentation. So now we are concluding by saying that sealing the pit and fissure sealants of pit and fissure, sealing the pit and fissures by sealants of primary and permanent teeth is an effective method for preventing and arresting the caries. However, the long-term success is dependent on regular checkups and the renewal of the sealing is required. That's all for presentation. Thank you.